Hi, everyone. My name is Morgan Harrington, and I am the National Coordinator of Programming for the American Liver Foundation. I'd like to be the first to thank you for joining us for our pediatric liver cancer webinar today. I'd also like to take a moment to acknowledge our generous sponsors, Merck and ISI, for their support of the American Liver Foundation Liver Cancer Series initiative. We are grateful for their ongoing support with our new series. I'm excited to share today that we are joined by Dr. Mercedes Martinez, who is our featured speaker. We are so appreciative that she was willing to take time out of her day to be here with us. Dr. Martinez is a professor of pediatrics and medicine at Columbia University, as well as the medical director of the intestinal transplant program at the Center for Liver Disease and Abdominal Organ Transplantation at NewYork Presbyterian. Dr. Martinez is nationally and internationally recognized for her expertise in treating liver tumors, as well as autoimmune liver disorders. At this time, I will go ahead and turn the program over to Dr. Martinez.
Welcome, and thank you for taking time out of your busy schedule to listen to this webinar, titled Challenges in the Diagnosis and Management of Liver Tumor in Children, sponsored by the American Liver Foundation. I'm Mercedes Martinez, and thank you for this nice introduction. We are going to review key points of the clinical presentation, diagnosis and management of selected malignant pediatric tumors. We focus mainly on hepatoblastoma, hepatocellular carcinoma, and the subtype fibrolemar hepatocellular carcinoma. Let me introduce you to the liver. It is the largest organ in the body, located in the right upper quadrant of the abdomen, just beneath the diaphragm, and on top of the stomach, intestine, and kidneys. In the right side, I have a cartoon demonstrating that the inflow of blood to the liver comes from two sources: the hepatic artery that brings oxygenated blood, and the portal vein that brings nutrients-rich blood coming from the intestine. This dual blood supply of the liver is unique. No other organ in the body has this blood coming from two sources. The blood leaves the liver to the heart via the inferior vena cava, and also we have the common bile duct that bring the bile flow produced by the liver to the gallbladder and intestines. Now we have this high view of the liver. I'm going to introduce a few more details that might be relevant for patients with liver tumors when we are talking about location and resections. The liver can be divided on right and left lobe if we draw a line along the side of the mid-hepatic veins. The right lobe can be divided on left lateral segment 2 and 3 and left medial segment 4A and 4B if we draw a line along the side of the left hepatic vein. If we draw a line along the right hepatic vein, this divides the right lobe on right anterior segment 5 and 8 and right posterior segment 6 and 7. This is very important to understand when doctors are talking to you about what part of the liver will be resected, what kind of resection is required, depending on the location of the tumor. I also want to mention that the liver is one of the most important organs in the body, and no bias at all, and a liver doctor. And the liver will have more than 500 functions. Among them is the production of the bile that we talk about, but also keeping stability of a lot of substances in the body, produce clotting factors, also is responsible for keeping the hemostasis of the glucose, and is responsible also for the processing of medication, detoxifying certain substance. The one that is most known for is the detoxification of the ammonia that can be excreted in the urine via urea metabolism. Then when we think about liver diseases, if the liver is so important and produce so many substances and clear so many substances, what are the symptoms of the patients with liver diseases? They are very well known, and people think about those all the time: lethargy, confusion, nausea, vomiting, bleeding, jaundice, which is coloration of the skin and the eyes. And when the doctors evaluate the patients, we look for those symptoms: jaundice, enlarged spleen, enlarged liver, maybe some bruises, among others. And when we order blood work, then we look for elevated bilirubin, low albumin, abnormal clotting factors, low glucose. But the reality is that when a patient has a liver tumor, might not have any of these symptoms. And this is the first challenge: how a doctor or a patient is going to suspect that they have a liver tumor if most of the time they don't present early on with any of these symptoms. As a matter of fact, the clinical presentation of the liver tumors in children most of the time is mass effect, when the tumor is so big that can be protruding the abdomen, causing abdominal distension and abdominal pain. The number one complaint of patients taking these patients to the doctor sometimes is constipation. Why? The patient might not be really constipated, but parents associate the abdominal distension to the patient's constipation, and maybe if the patient is not having frequent bowel movement, this is what the parents observe, and they take the patients to the doctor. And sometimes it's very difficult to perform a physical exam on a 2-month-old or a 2-year-old or a 5-year-old because they are feisty. And for that reason, they present late. They may have vomiting, they have lack of appetite or weight loss. And very rarely, this tumor may rupture, which is a very dramatic presentation. Sometimes also the tumor is so big that the patient has difficulty breathing, and they have something called respiratory distress, even requiring some respiratory support. Most patients, if you want to diagnose them early, they are asymptomatic. And the best way to find them is an incidental finding when an imaging ultrasound or CT scan is ordered for other reasons or for other symptoms, not really suspecting a liver tumor. Or in selected group of patients that have an increased risk to liver tumors, those patients get a screening imaging, and those patients have the benefit to be diagnosed early. Very important to recognize that liver enzymes, bilirubin, and clotting factors are often normal, even when the liver is full of tumors. One subtle laboratory value that might be important to remember is the elevation of the platelets, called thrombocytosis. If the platelets are more than 500,000, that might be a hint, but that can happen for many other reasons, and doctors usually don't associate that to liver tumors. Then the most important and reliable way to evaluate these patients is with imaging, trying to look at the liver. I think that one of the imaging modality that is available even at the bedside now in doctors' offices, in the emergency room, is abdominal ultrasound. And this is a very good screening tool. I'm going to show you this image. Then this is an abdominal ultrasound. On the right, this is a totally normal liver. And here on the left, you don't have to be a doctor to know that this is abnormal. Very rudimentary study, doesn't give us a lot of detail. What he gives us is the power to order new studies. And the ideal study for the evaluation of patients with liver tumor is to do a magnetic resonance image. MRI is how people recognize this modality. Usually, if we are ordering this suspecting liver tumors, there are special contrast agents that the doctors are very familiar with. And this is so powerful. This study is so powerful that the diagnosis can be made in patients with cirrhosis just by looking at the MRI. And this is an example. This patient here has an MRI pre-contrast. Doesn't look that much. When you give contrast, this tumor becomes extremely bright. And when we wait a few minutes and we call this post-contrast, we see like a hole in the liver. We call this washout. Then if you have a patient with cirrhosis and have these images, you can confidently say that this patient has hepatocellular carcinoma. Then very powerful for this. It's also important that the MRI tell us exactly the extension of the tumor. If there are vascular thrombosis, then it's essential to determine the extension of the disease and allow us to give prognosis to this patient. The use of CT scan is very limited in patients with liver tumors. Only certain patients should get a CT scan. And these are the patients that have an absolute contraindication for an MRI, like those patients that have an anaphylactic reaction to contrast or have metal implants that are MRI not compatible, if they have like a pacemaker that can malfunction. The other thing that is very different is the pediatric patients for an MRI might require anesthesia. They are small babies, they don't cooperate, they don't stay still for a prolonged period of time, which is the requirement for the MRI. The CT scan is pretty quick. Then if you don't have pediatric anesthesia available, or the patient is getting multiple anesthesias, then because they need to image several parts of the body, that might be a time that you might choose a CT scan. A time that the CT scan is indicated for this patient is to evaluate the chest for chest metastasis, because it's a better modality since the MRI requires that the patients don't breathe. Having a CT scan is better to demonstrate the presence of metastasis, as I show here in this image. Then imaging is the most important tool to begin the evaluation. Then are the pediatric tumors frequent in children? The reality is not. They are rare, but we have seen an increased tendency of this tumor in the last 30 years. The most recent incident is 3.2 tumors per 1 million patients, and this is in patients less than 20 years of age. Let's focus now on hepatoblastoma. Hepatoblastoma is the most frequent primary liver tumor in children, representing about 80% of the children, and also have an increased incidence in the last 30 years, as shown in this graph. 2/3 of the cases occur in children less than 2 years of age, and about 90% of the malignant tumor in children less than 4 years of age are hepatoblastoma, as shown in this graph. Hepatoblastoma sometimes is an sporadic tumor, doesn't have any genetic predisposition, except in these specific cases. In patients with trisomy 18, Becker-Wiedemann syndrome, familial adenomatous polyposis, and very low birth weight infant. For example, patients with Becker-Wiedemann syndrome have a relative risk of 2,000 of having hepatoblastoma. Compared with babies that are very low birth weight, those that are less than 1,000 grams have a 15 times relative risk compared with those patients that are more than 2,000 grams. And for that reason, for those patients with very high risk, as the Becker-Wiedemann syndrome and these growth syndromes, there is a recommendation that children undergo frequent screening with ultrasound and alpha-fetoprotein every 3 months during the first 4 years of their life. Then it's very intense protocol, but it's important to have an early diagnosis, and screening with imaging and alpha-fetoprotein is the only way to do that. Here, I'm showing you the importance of histology in the diagnosis of hepatoblastoma. When we talk about histology, we are referring to how the liver cancers look under the microscope. On the left side, here, I'm showing you what a beautiful normal liver is. And on the right side, we can see how distorted this histology is. You don't have to be a doctor to know that there is something significantly abnormal in this liver. Then you might think that making the diagnosis of hepatoblastoma histologically is easy. It might be easy to say that this is hepatoblastoma, but there are many types of hepatoblastoma. There are 2 major types, epithelial and mesenchymal type, and they all have different subtypes. And knowing exactly what subtype your patient have is very important for prognostic and for management. For example, we know that pure fetal types with low mitotic activity have a good prognosis, while patients with small cell undifferentiated type have a bad prognosis. And there are protocols that have been designed to treat these patients different. Alpha-fetoprotein, this plasma protein that is produced by embryonic yolk sac and fetal liver, is attached to the diagnosis of liver cancer. And this is because 90% of children with hepatoblastoma may have elevated alpha-fetoprotein levels above the expected value for their age. Alpha-fetoprotein might not be a reliable marker in early infancy because, as I said, it's made in the yolk sac, is made by the fetal liver. Then at birth, this patient have very high values. But if you train those values over time, you will be able to to evaluate whether the values are coming down, and this is just the natural history of the alpha-fetoprotein, or if the values are rising, you need to be concerned that this patient that maybe is at risk for hepatoblastoma might start developing hepatoblastoma. The very interesting findings is that the initial levels of alpha-fetoprotein might not clearly correlate with the outcome, except on those cases that have low alpha-fetoprotein. Then sometimes people say, oh, they have a liver tumor, but the alpha-fetoprotein is low. That should be good, eh? And it's not true. The patient still might have a hepatoblastoma, and in those cases is associated with an undifferentiated or anaplastic histology, which may predict poor outcomes. They don't respond well to chemo, they present late, they progress despite chemo. Then it's important to recognize that low alpha-fetoprotein doesn't mean that it's a good outcome. But alpha-fetoprotein is a sensitive marker and can predict persistence of tumor while the patient is getting treatment or recurring tumor after treatment is complete. Also, the rate of how the alpha-fetoprotein drop while getting chemo, it could be a good prognostic factor. For example, we know that those patients that the alpha-fetoprotein decrease more than 95% during the chemotherapy, by the time that they get resection or transplant, those patients might have a low rate of remission. In contrast, those patients that the alpha-fetoprotein doesn't decrease, that 95% have 50% chance of recurrence after resection or transplant. Then the treatment of hepatoblastoma is multimodal. We totally agree that it has to be a combination of chemotherapy and surgery. What not everybody agree is the sequence of how you are going to administer these two interventions. For example, the study of the International Society of Pediatric Oncology, or COPL, they recommend delay surgery. They advocate for chemotherapy first, which is something that we call neoadjuvant chemotherapy. Is chemotherapy before resection. And they make the case for that because they think that the chemotherapy will make the tumor smaller, less prone to bleed, make it more demarcated and differentiated with the hepatic parenchyma, which will translate in smaller resections and better outcome. On the contrary, the Children Oncology Group and the Society of Pediatric Oncology and Hematology advocate for resection up front, if possible, followed by chemotherapy, which is called adjuvant chemotherapy. And they make that case because they feel like if you do the resection first, you can minimize chemotherapy exposure and toxicity. And also, very important to recognize that a small subgroup of patients with pure fetal histology and low mitotic activity index, well-differentiated fetal hepatoblastoma, can be treated only with resection without need for chemotherapy. I cite here a case that we reported several years ago of a small child that have one of these well-differentiated hepatoblastoma. We did the resection up front without biopsies, and she never got chemo and got cured with resection only. And it was very relevant for this child because she has a condition in her kidneys called polycystic kidney disease that predisposed to renal failure. Then chemotherapy has been very detrimental for her kidneys. And this way she was cured and we protect her kidneys. Then how do we decide how to do resection or liver transplant? Then this is based in this cartoon, which is very complicated, but I'm going to walk you through. And hepatoblastoma resection is based on the extension of the tumor, which is called pretext. You remember how I explained to you that we divide the liver in 4 segments: the left lateral, the left medial, the right anterior, and right posterior. Depending on the location of the tumor, if the tumor is located in any of the extremes, one or the other, and we can do the resection, leaving 3 sections of the liver behind, then that is a pretext 1. Usually these patients do very well. If the tumor involves 2 of the section, right or left, and you just need to resect the right liver or the left liver to cure or to remove all the tumor, that is a pretext 2. Pretext 3 means that there is an extension beyond the midline. Then to remove that tumor, you need to do something called extended right hepatectomy, where you remove the right side of the liver and part of the left, or you need to do extended left hepatectomy, where you remove the left side of the liver and extend it a little bit to the right. That is pretext 3. If the tumor is included in the whole liver or multifocal, that give you no option for resection, that is the pretext 4. Things that we need to know about the liver tumors is that 60% are unresectable at diagnosis, and 20% remains still unresectable after chemotherapy. And for those patients with 20%, liver transplant is indicated. And just want to remind you, this is pretext 3 and 4 patients usually. For pretext 3 is mainly when patient has significant vascular invasions that you cannot do a good oncological resection. What is the outcome of these patients with liver transplant and resection? In the last decade, we have made significant advancements in the way that we treat surgically or transplant and this patient, whether it's resection or surgically. And this cartoon on the right is demonstrating us that whether you do liver resection or liver transplant upfront, this patient have an outstanding 85% long-term survival, which is outstanding. Then how you can get your patients to transplant or resection? First of all, if the tumor is not resectable up front, or you decide to go up front for chemotherapy, the patient have to have imaging after the second round of chemo. If after the second round of chemo, the tumor is not resectable, then you need to refer this patient to a liver transplant. If the tumor is resectable, then the patient goes to resection. When you refer your patient for liver transplant after the second round of chemo, you continue giving chemo to the patient while the patient meet the liver transplant team, they get into the transplant evaluation. And after the fourth round of chemo, you re-image your patient. If the tumor is resectable, the patient goes to resection. If the tumor is not resectable, then the patient must go to transplant. And I think that this is what has made the difference in the last few years, that we follow this protocol, early referral to surgery and transplantation, and start the discussion and the evaluation of your patient. The other thing that have made a huge difference is the priorities in the waiting list. We have made these patients one of the highest priority, called status 1B. That means that the patient will be getting a liver soon after getting listed, sometimes just with a few weeks. That means the patient doesn't have to be in a window without chemo, risking an extrahepatic metastasis, or the patient doesn't have to get extra chemo and more toxicity. Then these priorities are very important. Important to know that to receive this priority, the patient cannot have any extrahepatic disease. If extrahepatic disease was present at diagnosis, this could have been eliminated by resection or chemotherapy. And then this is examples of the first 21 patients that we transplanted for hepatoblastoma. We observed an excellent outcomes, close to 80% of the patients, but just try to think what we can learn from this patient. We have 3 patients dying in this cohort. The first patient have several lung metastases undergoing resection before transplant and chemotherapy, and we thought that the disease under control. The patient was transplanted, the disease came back. Then when you have to go several reiteration of lung mets resection, that might not be a good case for transplant. There was a patient that got a resection and got a transplant after resection that is called rescue liver transplant, and also have lung mets. This patient have significant recurrence after. And then there was the third patient that looks like any other normal patient without risk factors, underwent transplant and developed lung mets after. And after 3-4 years of resections or chemo, the disease took over and the patient died. Then I think that the message here is, if the patient have extrahepatic disease and that we represent him in blue, they have worse survival than the patient without extrahepatic disease before transplant. I think that one of the biggest dilemma or debates in patients undergoing liver transplant for hepatoblastoma or surgery is whether we should try to do liver transplant upfront for those patients that we think surgery might be questionable, or we will go for resection and then do rescue liver transplant. And this debate has been fueled over the years by all this observation. These three reports here on the box advocate for primary liver transplant because the outcome of the rescue liver transplant, that is the second line, was really poor, 82 compared with 36, 90% survival compared with 25, or 83 compares with 47. It's really telling us if you do transplant upfront, these patients do better. But don't go that fast. We have the counterpart here. These are almost 500 patients in these two reports that demonstrated, or at least revealed, that the long-term outcome of patients with primary or rescue liver transplant have similar outcomes. Then the jury is still out there. We don't have an answer for this, but it's something for you to think about. The other thing that is important is what happened when the tumor come back. And this is unanimous, people that have reported this. If you have tumor relapse after the liver transplant, basically the survival is very poor or no survival, while the patients that don't have any relapse have almost 100% survival. Then the key here is patient selection. Try to do the transplant early rather than late, and try to make sure that you do adjuvant chemotherapy and prevent recurrence in your patients. Then these are the prognostic factors. Good prognostic factors, patients that are eligible for primary resection, that have pure fetal histology, and that have a significant response to chemo with more than 90% decline in the alpha-fetoprotein for those patients that make alpha-fetoprotein. Poor prognosis factors, patients that have an alpha-fetoprotein less than 100 because it's associated with undifferentiated histology, alpha-fetoprotein of more than 1 million, a diagnosis because it's associated with vascular invasion and metastasis. Also, those patients that have a tumor rupture with contamination of the abdominal cavity, and patients that have less than 95% decline of the alpha-fetoprotein at transplant, since that has been associated with about 50% relapse after transplant. Let's move now to hepatocellular carcinoma. This is the leading cause of liver tumor in adults. It's the 5th cause of cancers in adults, and the 3rd leading cause of mortality for cancers worldwide. Then really, when you think about these numbers, wow, there are very high numbers of hepatocellular carcinoma. But the reality in pediatric patients is different. This is a rare condition in pediatric patients, and as you can see here, has been more or less stable over the last 30 years, with less than 1 incidence per million. These tumors present in 2 different peaks. Early in life, less than 4 years of age, this usually is associated with certain metabolic condition or some cholestatic disorders in children, and the other is 10 to 14 years, and these are the tumors that arise in a healthy liver of the fibrolamellar type. Then, as I said, the risk factors for adult hepatocellular carcinoma is cirrhosis. Contrary in pediatric, we see that 70% of the children have non-cirrhotic background in the cases of hepatocellular carcinoma. And these are the conditions that can predispose to non-cirrhotic ACC. The cirrhotic ACC is very similar to the adults. The etiology is viral hepatitis, autoimmune conditions. Of course, because there are pediatric patients, there are some genetic and metabolic conditions also that predispose to cirrhosis and ACC. I want to pay special attention of hepatocellular carcinomas and hepatitis B, because in patients with hepatitis B, ACC can arise from liver cirrhotic or non-cirrhotic liver. Then you can have a patient without cirrhosis and still they can have hepatocellular carcinoma, which is different from hepatitis C and other causes of liver disease. And the risk factors associated with this HCC is perinatal transmission, because the hepatitis B virus is in the body and in that liver since birth. if they are male, if they have this type of genotype called genotype B, if they have very high virus in your body, we call viral load, or if they have a family history of HCC. This family history of HCC might be telling you that they have the same genotype, there is transmission within the family, or that the immune system of these families are predisposed then to have HCC. But one thing that is very important I want you to know is that it's one of the few cancers that is preventable by vaccination. If we vaccinate the patient, prevent hepatitis B, we are preventing cancer. This has been very well demonstrated by this report from Taiwan. They started the hepatitis B vaccination in 2003, and you can see here the significant drop of liver cancer since the vaccination. And the pediatric patients that are in dark blue never were that many, but has been virtually eliminated HCC due to hepatitis B in Taiwan. Then please vaccinate. I also want to remark fibrolaminar hepatocellular carcinoma. This is one of the most rare liver tumors, represent about 25% of all pediatric hepatocellular carcinoma, and affects mainly adolescents and young adults. The histological characterization is bands of fibrous and eosinophilic foci. These fibrous bands are the ones that give the name of fibrolaminar hepatocellular carcinoma, and usually presents in very advanced stages with extension disease in the peritoneum or metastasis. These patients have no predisposing risk factors and have a normal alpha-fetoprotein. Then it's very difficult to say this is a cancer in a patient that have no factors and might have a small mass in the liver. People might forget about that even if it was seen. This serum haptocorrin, that is a vitamin B12 binding protein, is very elevated in most of these patients. What is really remarkable is the discovery recently of this DNA JB1 PR-KAKA fusion gene. A mutation of this gene is almost universally present in these patients with fibrolaminar HCC, and it causes a dysregulation of the catalytic PR-KAKA protein. Also causes a dysfunction of the ornithine carboxylate, predisposing to accumulation of certain amino acids in the body, and predisposing to one of the most bizarre clinical presentations in patients with liver tumor, that is hyperammonemia. They are knowing liver failure, they have normal numbers, they have normal clotting factors, but the ammonia levels can be that high that they can die of brain herniation or edema due to hyperammonemia. Then the recognition of this have been saving a lot of life, because now we know this patient can be hyperammonemic, we can be vigilant to start the treatment that many times include dialysis. Then this is a very different type of cancer than what we are known to encounter in the past. Then how do we treat the hepatocellular carcinoma? It's also a multimodality treatment. Very important to remark that pediatric patients enjoy good response to traditional chemotherapy. Adult patients will never think about sending a patient for chemotherapy, but pediatric patient, you must. And this is mainly very relevant for patients with elevated alpha-fetoprotein. We also can use immunotherapy. There is a lot of new medications that train your immune system to fight the cancer. Local regional therapy, very widely used for adult hepatocellular carcinoma. And here we take the benefit of that dual blood supplies that the liver have, the portal vein and the artery. Then usually we introduce embolization in the artery, and this we can use chemotherapy, blunt embolization, try to limit the blood supply of the tumor, or we can use radioembolization to try to destroy several tumors that are in one area. The other modality is something called cryotherapy, that this is when you freeze the tumor, you make the tumor very cold, frozen, and kill the cells. And of course, the traditional surgical resection, very special for pediatric patients is that they can tolerate extensive hepatectomy because the rest of the liver doesn't have cirrhosis. Then in adult patients, extensive hepatectomies are not tolerated because the remnant of the liver is sick with cirrhosis. But in pediatric patients, then you can be aggressive on the resection. And of course, liver transplant. And when we talk about liver transplant in anybody with liver cancer, there is always the thought about staging the tumor or the treatment of any tumor. There are many staging criteria in adults, the Milan criteria, San Francisco criteria, the Barcelona stagings. The reality is that none of this staging has been validated in pediatric. And actually, we have demonstrated that those children that present with very large multifocal tumors outside all these criteria can be transplanted with better outcomes than even adults. And this is due maybe because they are chemoresponsive, or is the different tumor biology. Then there are more and more people thinking that if you are going to stage a child with a hepatocellular carcinoma, you might want to apply the pretext staging of hepatoblastoma, which is not quite right. Then this is an area of significant disadvantage where we need to learn more how we are going to apply staging of patients with hepatocellular carcinoma in the pediatric age. And these are the examples of why within that day these criteria don't apply. In this study of 150 pediatric patients and 50,000 adult patients, they demonstrate that pediatric patients have better survival. And furthermore, when they analyzed the subgroup of pediatric patients, they found that 22 patients that went to transplant for complication of end-stage liver disease and found to have an HCC incidentally in the liver, they did pretty good compared with those patients that actually went to transplant for HCC. This other report of 11 pediatric patients, 8 of which are exceeding Milan criteria, enjoyed 72% survival at 43 months. Again, very nice observation, but you can remember the adult patients were talking about 15,000 patients. We are talking about 11 pediatric patients. It's a rare presentation, and we don't have the volume to assess and to draw criteria and algorithms for diagnosis and management. This is our experience at Columbia. This is a report of several years ago when we have transplanted 15 patients for HCC with a kind of okay survival, not as good as the hepatoblastoma, but you are exchanging a lethal condition of a patient that is not going to survive unless you do surgical resection, and you are giving a chance to these patients to survive. For the ones that do well, you did well. For the ones that didn't do well, then you have to admit that more studies are needed. But one important thing is that here we highlight the patients that are within Milan criteria in green and without Milan criteria in red. And there is a significant difference that maybe somebody said you shouldn't transplant patients that are outside Milan criteria because the outcomes are not good. But when you go further and stratify these patients of those that have extrahepatic disease and exclude those, when you only include patients without extrahepatic disease, then the Milan criteria doesn't mean much. You have very similar outcomes for these patients. Then it's not so much the extension of the tumor within the liver, it's the extension of the tumor outside the liver, which is different from hepatoblastoma. Remember how we said if you have extrahepatic disease, but this disease can be controlled surgically or chemically with chemotherapy, you are okay going to transplant. This is not the same in hepatocellular carcinoma. And in this cohort, we have 3 patients with more than 5 years survivals and 1 patient that has survived more than 3.5 years. Then really, this is no patient that were transplanted yesterday. This is patients that have endured that survival. In summary, liver transplant for patients with HCC has to be tailored based on histological type. Excellent outcomes has been observed in children with HCC within Milan criteria, but also liver transplant should be considered in patients with multifocal HCC, microscopic vascular invasion outside adults standard criteria. But we also know that liver transplant in patients with extrahepatic disease carry poor prognosis, and that I will not recommend it. Then in summary, malignant pediatric tumors are rare, and for that reason, patients should be cared at experienced center. You shouldn't go to a center that take care of one patient with liver tumors every 5 years. You should go to centers where this is a decision that they have to make every couple of weeks. Then they have the experience, they have the volume, they know what to do. Pediatric liver tumors often present without underlying liver disease or cirrhosis, and for that reason, usually the presentation is late. Hepatoblastoma is the most common pediatric tumor, followed by hepatocellular carcinoma. And children has enjoyed overall good survival after liver transplant for both hepatocellular carcinoma and hepatoblastoma. A small sample size is historically limited our evaluation and treatment strategies. We cannot draw conclusions from 11 patients or 15 patients. We need thousands of patients, and like the adults do, those doesn't exist in any single center or even in every single region for pediatric. For that reason, multi-center studies using standardized stratifications are required to assess prognosis and risk factors. And I want to leave you with maybe the most important message of this talk. Regardless of the response to chemotherapy, pediatric malignant tumors cannot be cured without complete tumor resection in all this size of the disease. Then sometimes patients or doctors keep giving patients chemo after chemo because the tumor is getting smaller, hoping that they can do a resection or they don't need a resection. That's not true. You have to have complete resection of the tumor, even if that involves total hepatectomy with liver transplant. You are changing a disease that is lethal and that you cannot control with chemotherapy when you do a transplant for a disease. A transplant is a disease, but it's manageable. The patient is going to be in immunosuppression for life, but this is something that you can control in the majority of the cases. And I want to thank for your attention. This is my email. I will be happy to answer any questions.
Thank you so much, Dr. Martinez. That was an incredible presentation. And we are, again, just so grateful for the time that you took today to prepare everything and be able to be here with us. We did want to do a few question and answer moments here together. You gave us so much great information, and this is a perfect time to sort of summarize some of that as well. So one of the top questions is sort of overall, what does the survival rate look like for both hepatoblastoma as well as hepatocellular carcinoma?
Well, I think that hepatoblastoma patients enjoy excellent outcomes. 85% survival at 5 and 10 years of a patient with cancer is amazing. Then that right there is a statement that we have been moving the needle towards good outcomes in the last decades. And this, we have to give the credit to the oncologists. They enroll every single patient in clinical trial. They try to collaborate. They try to draw protocols. And this is why the treatment of cancer in children, the chemotherapy is so protocolized, because they know, and if they don't know, they will figure out. Then participation in clinical trials, enrollment in clinical trials, or even enrollment in prospective studies is very important. We learn a lot from those. Unfortunately, it's not the same thing for hepatocellular carcinoma. Hepatocellular carcinoma is not one disease, it's several diseases, very heterogeneous. We have patients with hepatocellular carcinomas that are rising from a cirrhotic liver, other patients that have healthy liver in the background, and then we have the fibrolamellar. And this, if you saw, these are very rare tumor, less than 1 per million. Then gathering the information, establishing protocols is very different, and it's very different. If you diagnose a patient with hepatocellular carcinoma early on, those patients might do better than even a patient with hepatoblastoma, because you can do resection, they don't need chemo, and they go and have a healthy long life. But the problem is that HCC present late, and mainly when the disease is already outside the liver. In that case, for example, we know that fibrolaminar patient has a very difficult outcome, most likely have a bad prognosis. But if they are diagnosed early, those patients do very well with resection and may have a better outcome than patients that have a HCC rising from a cirrhotic background that most likely are going to need a transplant. Then it's difficult to assess overall, but I will say, if you ask me for a straight answer, hepatoblastoma patients do very well. Hepatocellular carcinomas, the outcomes are still low, and I want to call for actions to do more research and to try to improve the life of these patients.
Thank you. You did mention clinical trials a little bit there. Can kids with these forms of liver cancer participate in clinical trials?
Well, all kids with this kind of cancer should participate in clinical trials. And there are different types of clinical trials. There are clinical trials when they are studying one new medication, or there are clinical trials that they are changing the medications, they are changing the protocol a little bit to reduce, for example, the toxicity of the chemotherapy. We are usually traditional, most of the chemotherapies for hepatoblastoma involve 3 or 4 agents. More recently, we are doing clinical trials for those patients that are low risk, giving only one agent to try to minimize the toxicity. Then clinical trials come in different forms, and I'm telling you, the oncologists are going to approach you to be part of clinical trials because this is what they do, and they have results in an amazing outcomes of pediatric cancer overall.
That's great. That's such great information to share. You also mentioned in your speech about going to experience centers. And of course, not everyone lives close to where you are. Are there other experience centers that are sort of top of mind for you that you would recommend for patients, or would you primarily recommend patients reach out towards your direction if they are receiving these diagnoses?
Well, I don't think so. You know, we get patients from all over the country and all over the world, sometimes in desperation, because even when you go to experience center, sometimes the experience centers doesn't want to take the risk. Every time that we transplant a patient with a very extensive liver disease, mainly HCC or even hepatoblastoma, every time that you transplant a high-risk patient, you are taking the risk of the outcome of your center. We get all judged by outcomes. Then I think that smaller centers might not have the bandwidth of affording poor outcomes. If you are in a year where your center already is having poor outcomes, even if that is an experienced center, they might not want to take the risk with that patient. Then be mindful that if one door closed, go to the next one. There are experienced centers. You can go to the OPTON website and you will see what are the centers with the highest volume of transplant. About 60% of the transplants, despite that there are close to 100 pediatric liver transplant centers in the United States, 60% of the transplant happen in the top 15 or 20 liver transplant center every year. Then go to the OPTN website and look at what are the centers that are closest to you and knock that door first. And we have patients coming to us after being evaluated in 5 centers and being told no. And we take the risk. That we might not be able to do that all the time. It depends how our outcomes are. But fortunately, we enjoy really good outcomes overall in liver transplant that most of the time we can take the risk. And I know that most centers will do that also. Then go to the OPTN website and you will find the information there.
Wonderful. And then my last question for you is, if there were 3 things or recommendations that you could share with all parents of children who may have new diagnoses of either one of these liver cancers, what would those 3 things be? What are 3 strong recommendations you would provide to those parents?
I will say first, I know that this is a very difficult diagnosis, but remember, you don't get measured for how many times you fall, you measure for how many times you rise. Then I know your child is sick. The only thing that you can do is fight and look for options, get educated, read, try to find somebody that can be your ally, somebody, maybe you are not a person that understands science a lot or understands physiology a lot. Maybe you are a person that are very well educated, but you are numbers, or you are, try to find people within your family, with your friends that can be your ally, that you can talk to, that you can run recommendations. Sometimes people are naturally suspicious about clinical trials. People are naturally suspicious about new things. Well, for your child, maybe the best option will be a clinical trial or a new thing if there is no any other options. Try to ask about guidelines. Guidelines, when they exist, are the best. Then if you are having a child with hepatoblastoma, try to talk with your doctors about what are the guidelines, how you treat this. How many patients have you treated in this center within the last year or 2 years? What is your experience treating this patient? Who do you collaborate with? And ask the tough questions up front. And I know that it's difficult, but try to be hopeful, but prepare for things that might come your way that is not what you want or you expected. And if you take that physiology and you are ahead of the game, educating yourself and preparing yourself for bad things, that might be good. Don't overthink it. Don't think always that bad things are going to happen. I'm telling you, hepatoblastoma survival is 85%, whether they need a transplant or resection. This is amazing. If you have a ACC, then you need to think, what is the extension of the disease? I'm trying to educate your child. The other thing that we have encountered is when the children are older, they want to know what is going on. And sometimes the parents want to protect them from knowing. Knowledge is power, and powers make you feel in control. And this is very important if an adolescent is going through difficult times of having a diagnosis of cancer.
That is wonderful advice, and I really appreciate you taking the time to share that with us. I do just want to go ahead and thank you again so much for being here with us today and just providing such an incredibly informative presentation for us. We are grateful for your expertise and, of course, your willingness today to carve out a little bit of time to share all of this with us. We, of course, want to thank our sponsors one last time of Merck and ISI for their support. And if anyone has any questions or want more information about pediatric liver disease or liver disease in general, we are always welcome to visit our website at www.liverfoundation.org. Thank you again.
Thank you for all you do for patients with liver disease. Thank you.